I work at Birmingham Children's Hospital. I also work at the University of Birmingham, which is where I do most of my research, although I'm sort of clinically orientated with most of that. Yeah. A little bit loud. Oh, I see. Okay. And I can't do all the stuff that I do without all the support of these people and those people up there. So I'm going to talk about green. I'm not wearing green, but that's what I'm going to talk about. I'm going to talk about this, which you may or may not ever have heard of, which is called indocyanine green, which is a dye that we use, or I use, during almost all my oncology operations. There's a bit of science, which I'm not going to bore you with, mainly because I don't understand all of it either. But basically, it's a dye that we've been using since about 1956 in humans. And so there's really good data on it because it's been in use for 65 years, something like that. It was originally approved in the 1950s, and they used it to look at the back of retinas and to look at cardiac function and liver function and things. And so we know that when it's given, it comes out of the bloodstream into the bile and then disappears, and it doesn't interact with anything. And if you give it into the bowel itself by mouth or by nasogastric tube, it does nothing but sit there and come out the other end. So if you had this and you were really interested, you could go and look at your poo afterwards and see whether it had dye in it. But I wouldn't advise it, not in public anyway. So it's been in practice, in use in the adult world of surgery for probably about 10 years or so. And they use it for looking at things when they do gallbladder operations, when they take out bits of bowel and join them together, when they do some tumour operations, and they also use it to look for lung metastases, so when the tumour's moved and there's some part of it in the lungs, they use it to look for that. And they also use it to look for lymph nodes, which are all these things that you have everywhere. And if you've had lymphoma, you will know that the lymph nodes can be anywhere. So that's important. Note. Yeah. So what? So you're going, that's really interesting. But so you'll all be familiar with this. This is invisible ink. So you can't see it when you write on a piece of paper until you do that with the ultraviolet. And then you go, oh wow, it says something. So the dye, like invisible ink, you can't see it unless you shine a special light on it, which is infrared. So if you're going to look at your poo, you need an infrared light. Okay. Noted. Put that in the min. Oh no, you're re-recorded, so it's all good. So you inject it. You can almost inject it anywhere, actually. But if you're going to inject it into the bloodstream, it then hits the bloodstream and then passes into the tissues. And then if you're not shining infrared at it, you can't tell that it's there. But if you are, then you can. So how does this help all of our children? It helps them because you will all be familiar with drugs given to children. You will all be familiar with all sorts of familiar with clinical trials. And most of the drugs that we use in children aren't licensed for use in children. We just make up the dose. This one is actually licensed for use from the day you're born, which is really unusual. And some of the literature that they have on their website shows that they've actually used it in premature babies. 500, 600 grams. So that's a good start. The only problem with it is that sometimes you get a severe allergic reaction, and that affects less than 1 in 10,000 patients. I'll put that into context. This is an adverse drug reaction form that all drugs have, that is in the BNF, the British National Formulary. And it lists all the possible complications and lists there how often they happen. Now, this drug, where is it? Has an allergic reaction of, where's it gone now? Anaphylaxis. Very rare. Very rare, less than 1 in 10,000. Anyone hazard a guess what that drug is? Okay, so it's on, you know, you give that to your kid, they go, oh, I've got a bit of tummy ache. I go, if you're like me, it goes away, okay? So I use that during my operations because it gives me high contrast. It's really quite sensitive for some things, but not that sensitive to others. It doesn't cost that much in the grand scheme of things. It's about £60 a vial. So some of the kit that I use when I'm operating is £200-300 a pop. So some of the kit that I have in theatre is single use, and so it's 3 times as much as that. I don't need to use X-rays or anything like that. Infrared's really safe, as far as we know. It's really easy to use, it's really safe, and it offers me something that normal surgery doesn't offer, which is this. From an oncology perspective for tumours, these people in the 1980s in Japan described this effect where the ICG accumulates in tumours and disappears from everywhere else. You can see the obvious benefits of that when you're doing an operation. Sometimes you can't tell where the tumour stops. And so you end up taking out more tissue than you need to because you're worried that you're going to leave some behind. Or worse, you don't take out enough. Okay. My particular interest is kidney tumours. And the kidneys don't look like that, but they do. It's a good schematic representation. I have to thank Ellie for all the graphics in this, apart from 1 or 2 slides, because she's just said, I'll just draw these for you. So I'm going to put, if you ever come to any more of my talks, they're all going to have these slides. So those are the types of kidney tumours that we see in children, most commonly. And the operations, has anyone had a kidney tumour? Anybody had a child with a kidney tumour? No? Okay. You'd know this already, probably. There's 2 things that we do during an operation for kidney cancer in children. Most of them will have chemotherapy before they have their operation. At their operation, we have to take out lymph nodes, which is why I mentioned those before. And then we have to take out the tumour. Most often that involves taking out the whole kidney because it's difficult to separate the normal kidney from tumour. And also we tend to take out more kidney than you need for that kidney to function. That makes sense. And so we have to take out more than 6 lymph nodes. These are the guidelines that we get from the International Oncology Group that we follow as CCLG. Every type of tumour has its own set of guidelines about how you're supposed to manage it. So this is what we do with kidneys. The problem with lymph nodes is that they're quite small. If you don't know about lymph nodes, basically they drain excess fluid that the veins don't take away. This can include tumour cells. If you look at them on ultrasound, if they're 1 centimetre, they're big. So 1 centimetre is about that big. When we do the operations, we're really bad at finding lymph nodes. I don't just mean me, I mean everybody in the UK, Europe, North America. All the literature suggests that we take out about 4 most of the time. And the reason for that is they're really small. You can't see them. Sometimes they look like fat. And so when you take out a bit, you think, oh, this is fat. And Dr. Bowen tells me that it's fat and not lymph nodes. But I only find that out 2 weeks later, which is obviously too late. Everything looks the same. It's a bit like operating on jelly sometimes. You don't know which bit of jelly is the lymph node and which bit isn't. And most of the time, they're right on top of all the massive blood vessels that you've got in your abdomen. So actually taking them out sometimes is really quite dangerous. So I sit on this committee, the Renal Tumour Study Group, which basically sets the oncology guidelines for kidney tumours for about 1/3 of the world or something like that. We have conferences every year. And so in order to propel my hypothesis forward, I wanted to take it through the international group. Now, we happen to have a meeting in this place. If you've ever been to Rio, it's brilliant. So we talked about how can we detect lymph nodes better using indocyanine green. Now, in the adult world, they inject it around the tumour, not into it. But I wanted to know whether, because you go to an international group of experts to find out the answer, don't you? But I had to go with some idea about where I wanted to inject the dye. Did I want to inject it into the kidney, into the tumour, under the capsule of the kidney, or directly into lymph nodes? And so we ended up talking about these options. So one, either you inject it into normal kidney, either you inject it into stuff around the kidney, or you inject it into the tumour. And so we settled on injecting it into normal kidney. And then we set up a research study. So Angela Blanco's down funded Bethany's wish. And it worked. So when I inject dye into the kidney, all the lymph nodes light up. I'll show you what that looks like in a minute. But then I published some data. This is how you get things through into the world of peer review and literature. Is I published a paper saying that in one patient I'd done this, and this is how it worked. So that other people around the world can go, oh, that's interesting, why don't we start doing that? And they set up their own research study, and then you get more and more data. That's what it looks like. So that's the same lymph node. That's looking at it with the naked eye, and that's looking at it with infrared, because it's got green stuff in it.
Really small.
Yeah, I didn't put a ruler next to it, but that's 7 millimeters, which is about that big, I think. And then you collaborate with people around the world, because Wilms tumours, we see about 80 of them in the UK per year. So not very many, which is great. Yeah.
Wilms tumours.
Commonest.
Yeah, commonest kidney cancer in children. So children's cancer.
Yeah. So you probably know, some of you may have heard of St. Jude, but it's a big centre in the United States, non-profit. Okay. They fund lots of things, actually. They've got an enormous amount of research funding input. Elon Musk, I think, gave them $1 billion, for example. So they're pretty well funded. Yeah. So if we could get Elon to come over here and fund some of our stuff, that'd be amazing. We collaborated, because they were doing something similar. Now, the management of kidney tumours in North America is slightly different. They don't give the preoperative chemotherapy that we do. But we collaborated on this study, and then we presented it at one of the international meetings. And we found that actually it works whether you give the dye around the kidney or into it. So in both circumstances. And we also found that actually the number of nodes that we take out on average is double what we normally do. So we got 8. And some of those nodes had disease in them, which means that actually, even though you're injecting into normal kidney, the nodes that have disease also go lighter. Because one of the criticisms of that is that you're not injecting into tumour, and then how do you know that it's got tumour in it? Does that make sense? So we thought it was pretty good. But we've only done 8 patients, which isn't very many. So you need a randomised control trial to show whether it works or not in large numbers of people. And then after I published that, we updated some of our numbers to show that if you weren't using ICG, your median number of nodes was 3, the average. And then if you were, it's a lot higher. Yeah. And so I then moved on a little bit from that. I still do that. That's like my standard of care in Birmingham, children with kidney tumours. But I then wanted to know, could we use it for anything else in kidneys? Now, some of our children, you don't take out the whole kidney, you take out part of it, because either they've got disease on both sides and you don't want to take both kidneys out, or they've got a predisposition syndrome, so something in their genetic code that means they're more likely to get kidney tumours. You don't want to take out the whole kidney, because they're more likely to get one on the other side, and then you run into problems. So sometimes we take out parts of the kidney. But we then asked the question, why don't we just do that in everybody? Why do we take out the whole kidney? Can't we just take out part of it? The problem being that we don't know where the tumour stops and normal kidney starts. So if we leave disease behind, it may come back. If we leave it behind, children will need radiotherapy. So we take out the whole kidney because we don't know where it stops. And it's the safest thing to do most of the time. So my friends in St. Jude in Memphis published some data on when they gave patients indocyanine green and then did their partial nephrectomy. So took out part of the kidney with tumour in it. And they found that Wilms tumour doesn't take up dye, but the rest of the kidney does. So if you get a good rim tissue that's green, you know you've got all the tumour out. But they weren't really using it to guide their resection. They just did it as out of interest after they'd taken the bit out and went, oh, that's interesting. I didn't really like that very much for applying it to use on my patients. So I wanted to know if I could use that in real life, but I didn't want to test it on people. That's not good. That's not proper research. That's not ethical. And I also didn't trust my eye to tell me where the tumour stopped, because I need to know where the tumour cells stop, not where the tumour stopped, nor where I think it stops. Because the cells are important, so if you leave cells behind, then like I said, the chances of it coming back are a lot higher. So I wanted to know if I could see with the naked eye and see under the microscope. Because the pathology is important. More about that. And so when we look at, when did I say we, royal we? Well, no, I'm good. Well, we did yesterday, anyway. Yeah. So if you're, so margin positivity is if you've got tumour cells at the edge of the specimen that you take out, it's positive. If you don't, it's negative. And so then I set up another study to do that. And what I do is, after I've taken the kidney out with its tumour, we put it on a table behind the patient in theatre, and then I inject indocyanine into the artery, into the kidney. And the kidney goes green, and the tumour doesn't, most of the time. There's lots of different cell types in Wilms tumour, and so we need to do this experiment, because that's what it is, on all the different types of cells, all the different tumours with different cell types, so we know that if it works in all of them. Because I don't know what cell types are in there until Claire tells me. She'll tell you. She's very clever. Yeah. And so then what we can do is shine the infrared light on it when it's on the outside and see where the tumour is. We don't cut it out necessarily like that when it's on the back table, but we can. And then we look at it under